Bismillah ar-Rahman ar-Rahim. First, I do like to thank the ATS Society for inviting me and Dr. Ashraf and Dr. Bassam and Dr. Qutaiba. And actually, when the COVID started, we have a lot of debate about the best treatment for COVID, and a lot of data was coming out with more conflicting data about COVID-19. Uh, with more advance of the disease, we get more accurate data about the management and the treatment of COVID-19 infection. And actually, there is no uh, special guidelines for COVID-19. All of publication or protocols are published by local health authority or local institute of health. And I tried to find out the best guideline to treat patients with COVID-19. And I found it at the end as the best one to use is the best one you adapted in your local guidelines. So I go through the United States Department of Health and Human Services protocol and NIH protocol and the European Respiratory Society Living Guideline on patients with COVID-19 infection hospitalized and our local guideline on treatment of hospitalized patients with COVID-19 infection. As Dr. Tobe said, as most of the severe patients with COVID-19 is almost just patients who are cardiovascular or diabetes more than chronic pulmonary diseases. One of the challenges in the treatment is the choice of best treatment for patients admitted with COVID-19. And this treatment is most controversial seen in patients admitted to hospitals with COVID-19. The ERS panel recommends treatment with corticosteroid in patients who are requiring the oxygenation, non-invasive ventilation, or mechanical ventilation, but not offer any recommendation for patients who are not in need of oxygen or ventilatory support. Our guideline goes with this one, with patients hospitalized who need require supplementary oxygen should be recommended for the use of steroid, but again, it's the use of corticosteroids for patients who are not in need of oxygen therapy. First data came from JAMA, with a randomized trial of 1,700 critically ill patients, and they saw reduced mortality on 28 days with using corticosteroid. And another systemic review was done with British Medical Journal, and the intervention was certainly moderate reduction of mortality. The largest study came from the recovery study, where there is a large number of patients, about 2,100 patients, assigned to dexamethasone versus 4,000 with usual treatment. And they conclude that the use of dexamethasone and dose of 6 milligram for 10 days resulted in 28 days mortality reduction in this patient, and they were away from mechanical ventilation. And patient who does not require oxygenation has no better care if they use the steroids. All participants or oxygen use only or patient invasive mechanical ventilation were better having dexamethasone as mortality issue. But for patients who are not receiving the oxygen, dexamethasone does not differ between the two groups. So the overall meta-analysis shows that steroids favor the reduction of mortality in patients with COVID-19. Of course, we can use the different equivalent doses of hydrocortisone or methylmidazole or prednisolone according to the equivalent dose of steroid of the 6 milligram dexa. Sometimes we use pulse therapy in patients who are not responding to usual dose of steroid, and they have very good response, especially patient admitted to the ICU. When they look for patients who discharge from hospital after taking steroids, there was no benefit from adding steroids for outpatient treatment for these patients. They didn't have any effect in their readmission or mortality if they continue on steroids. So it's better to cut the steroid once they are outside of the hospital. The second point was interleukin 6 or tocilizumab or other similar treatment, where the ERS pattern was recommending interleukin 6 receptor antagonist for patients who are hospitalized with COVID-19 requiring oxygen or ventilatory supply, but does not offer interleukin 6 receptor antagonist for patients who are not requiring oxygen or not receiving corticosteroid. In one study in Lancet 2001, about 4,000 adults of 21,000 patients enrolled in the recovery study was assessed for tocilizumab, and they receiving steroids. About 82% of these patients received steroid also, and they found significant reduction of mortality in this patient who received tocilizumab. Also, another study showed that 28 days mortality was reduced, and need for endpoint of mechanical ventilation was reduced. Mortality for the group of tocilizumab versus usual care was better, and the charge alive patients was better with tocilizumab. This is overall studies, and all favor to tocilizumab better outcome mortality. Our local guideline is usually up to date, and actually we have very successful patients treatment with these guidelines. And our recommendation is to have tocilizumab up to 800 maximum dose in combination of dexamethasone, 6 milligram at least daily. And I think this is very important for patients with monoclonal antibodies. The indication for patient hospitalized first day of admission or 24 hours of ICU who are requiring invasive ventilation or non-invasive high flow nasal cannula, more than 40% liter per minute. Recent hospitalized patients who are not in the ICU, but they have rapidly deteriorating oxygen need and they require a non-invasive ventilation or high flow nasal cannula, or their CRB is more than 75%. These patients have been benefit from using the tocilizumab, and we have very successful cases who use this monoclonal antibody. Bacitracin and JAK inhibitors, they are not used for long scale, and but they show that in some studies that they have some improvement on patient mortality. But in our guidelines, we found that there is insufficient data to use this monoclonal antibody alone or in combination with remdesivir. Also, the panel against the use of bacitracin without remdesivir, except in clinical trials, and there is insufficient data that recommends the use of bacitracin and the corticosteroid in the treatment of COVID-19, because both of them are immunosuppressant and potential of additive risk of mortality. Some data support the bacitracin treatment, but it's not wide used because tocilizumab was having other results, and the study shows better outcomes when used tocilizumab in these patients. Interleukin 1 has been inhibitor had been tested in Italy and Greece, and the problem with this one is the test is soluble urokinase plasminogen activator receptor is not common as interleukin 6 or other inflammatory markers. So nobody used it. Even they show some improvement with patient mortality and use of interleukin 1 antagonist, but still it is not widely used. Remdesivir is also one of the challenges treatment of COVID-19. The ARS does not recommend the use of remdesivir in patients not requiring mechanical ventilation, and says not to offer remdesivir in patients hospitalized with COVID-19 infection or require mechanical ventilation too. But in our guideline, we recommend this patient, so non-hospitalized, to have at least 3 days treatment of hospitalization, who require low supplemental oxygen. And actually, we find the response to patient so admit to the hospital without need for mechanical ventilation. They are improve on remdesivir 5 days treatment. It is not recommended for patients who require mechanical ventilation due to lack of benefits of this treatment in these patients. The first report from Interium, a report from WHO and the Solidarity study, they show that there is no difference between the use of remdesivir for patient mortality 28 days. The Act 1 trial was among patients who are not on mechanical ventilation. They did not reach a significant parameter or p-value, but even the values, the numbers was lower. And the study done in Canada, they found there was no statistically significant reduction of mortality in hospital mortality, but also they were not on mechanical ventilation baseline, reduced for the subsequent mechanical ventilation during hospitalization. One study came from Clinical Infectious Disease Journal, and this is were amazing because this one is a large comparative study for comparing all causes of mortality, and they included about 28,000 patients with remdesivir versus 16,000 not on treatment. And they found that overall, 14 days and 28 days, mortality rate was significantly reduced with remdesivir. Only patients who are high flow nasal cannula or non-invasive ventilation, they are only have lower risk for mortality 14 days, but not 28 days. Overall, the mortality was lower of patients receiving the remdesivir, whatever they are on high flow nasal cannula or ECMO or low flow nasal cannula. For the anticoagulation, the panel recommends the anticoagulation in patients hospitalized with COVID. This is strong recommendation. Our recommendation also to have anticoagulation or antiplatelet therapy to continue for patients who are aware before an anticoagulation. For non-pregnant ladies, should receive prophylactic anticoagulation if they are admitted with COVID-19. The our country is and sufficient data recommend on or against the thrombolytic or higher prophylactic doses of anticoagulation for hospitalized patients with COVID-19. Hospitalized patients should not be discharged with prophylaxis routinely, and also it could be considered only if patient has high risk for thromboembolic disease. For pregnancy of patients who have prior thrombolytic therapy should be continued on it. For pregnant ladies who are admitted with severe COVID prophylactic doses should be given. Unfractionated heparin and low molecular weight heparin and warfarin does not accumulate in the breast milk, so they can use it. There's many algorithms for use of anticoagulation of patients with COVID. Either they have any acute incidence of thrombosis or they have taking anticoagulation treatment. For hydroxychloroquine and the azithromycin and the colchicine and Caletra and the interferon, there is no recommendation anymore to use this one in our protocol. Our protocol is against the use of chloroquine or hydroxychloroquine with or without erythromycin. There is no benefit from mortality if we use it. Also, it's not significantly statistically, and colchicine is not also recommended. The ban does not recommend Caletra anymore in the management. Also, interference is not recommended anymore. and the use of interferon beta is not recommended. The convalescent plasma use is not also recommended now. Also, we recommend against the use of mesenchymal stem cell for except in clinical trials. For the antifungal and the antibacterial treatment, should be judged by the treating physician. COVID-19 is not the cause for VAB because of wrong ventilation, but maybe because of the change of la flora, which cause more VAB infection in these patients. This scheme for taking care of patients with COVID-19, if they have clinical picture and the immediate sampling is done and they have instability or severe hypoxemia, we start treatment and send the cultures and wait for after 24 or 48 hours to correct our regimen. For patients who gets VAB, if they have COVID, they have more mortality rates than patients who does not have COVID. To summarize, the main guidelines, the first one was this NIH guideline, which have recommended that hospitalized patients who does not require oxygen only recommends the use of dexamethasone. Do not recommend the use of dexamethasone, but they can use prophylactic heparin. Patients hospitalized require oxygen, they might use remdesivir and dexamethasone, and they might need therapeutic or prophylactic heparin. Patients hospitalized and require high flow oxygen or non-invasive ventilation, they have to use dexamethasone or remdesivir, and they have to use prophylactic heparin. Patients hospitalized who are using ECMO should have dexamethasone plus tislelizumab, and they have to use prophylaxis heparin as well. This is also another scheme by used in the United States for comparing patients according to the level of oxygen. If low oxygen, they use dexamethasone and remdesivir. If they have high flow oxygen or non-invasive, they can add tislelizumab to the treatment. If on mechanical ventilation or ECMO, they have dexa and tislelizumab added and this is a summary of the ARS guideline, a short guideline. Patients, all patients need anticoagulation, systemic steroid only in patient requiring supplemental oxygen or mechanical ventilation, interleukin 6 for patient requiring oxygen or non-invasive ventilation. There is no fear about the use of profen in the beginning of the disease. Statin was not seen to have any effect on the death of patients with COVID-19. Other agents like hepatitis C antiviral has not shown any effect on this patient with COVID-19. Oxygenation, over-oxygenation of patients with COVID-19 is not beneficial. It's above, they compare liberal oxygen therapy versus conservative therapy, and they found that conservative therapy is better than liberal oxygen therapy. Patients who need high flow nasal cannula or non-invasive ventilation. High flow nasal cannula is recommended over non-invasive ventilation, and also a patient who suggests to have ventilation, they better to have low volume or low tidal volume ventilation and with plateau pressure less than 30, and the conservative fluid strategy, and not using nitric oxide for liberally in these patients. Also, if we use the higher positive expiratory strategy, and for extracorporeal oxygenation is not recommended, as there is no controlled trials to evaluate ECMO in patients with COVID-19. Even there was one study which shows that the mortality was 37 in this patient after 90 days. In our guidelines, there is very strict parameters used to have patients on ECMO, and this usually is very strong recommendations. This is some patients before and after treatment in our guidelines, and they were very successful. This is the last slide. Clinicians should consult their own local protocol for management, which may differ from other approaches, which is the best for managing patients. Thank you.